Welcome to Conversations in Bioethics, a podcast series in which we discuss contemporary bioethics issues with Cleveland State faculty and other professionals. Hi, I'm Tony Nicoletti from the Department of Philosophy at Cleveland State, and in this episode we will discuss the issue of transplant ethics with Dr. Mahwish Ahmad. Dr. Ahmad is a physician and transplant ethicist working in the bioethics department at the Cleveland Clinic. She is also an ethics committee member with the United Network of Organ Sharing, or UNOS, which oversees organ donation across the United States. Her interests include not only ethical issues in transplantation, but also issues having to do with healthcare and access disparities, women's health issues, child and adolescent health. She has published articles in academic journals such as Pediatrics, Journal of Pediatric Gastroenterology and Nutrition, Journal of Neonatal Perinatal Medicine, and World Neurosurgery. Welcome to the podcast.
Thank you for having me.
Thank you for coming. We appreciate it. So, being I mentioned UNOS in the introduction, and people may not be familiar exactly with UNOS or how it distributes and oversees organ allocation, can you say a little bit about how patients get on a list for transplantation, what they're looking for, how UNOS manages that, and also maybe you could talk a little bit about the ratio of available cadaveric organs to potential recipients.
Okay.
Some of those issues.
So to start, UNOS stands for the United Network of Organ Sharing, and the other acronym is Organ Procurement and Transplantation Network, which stands for OPTN. And this is an organization which is kind of a unique public and private partnership that links all professionals within the U.S. that are involved in donation of organs, procurement of organs, and transplantation systems, which include hospitals. So crucial to the system are individuals who sign donor cards, be it at a DMV registry point when you get your license for the first time, people who go online at donation.gov and sign up there, people who comment on policy proposal, and invested people in the transplant community who lend their expertise, and the countless volunteers who support donation and transplantation throughout, whether it's through a walk, there's one happening this Saturday, or through their expertise in the medical or the surgical realm in order to help frame and shift policy so that it's for the betterment of the patients. So with all of our collective efforts focused on the patients, the goals of OPTN or UNOS are that they work solely to increase the number of, and in turn increase access of transplantation for all patients that need transplant organs. They also have a national registry and maintain longitudinal data in terms of how to improve survival rates after transplantation, how to improve wait list ratios so that people get donated to and transplanted faster, and to improve their outcome post-transplantation so that they can survive for longer, and we can promote patient safety and efficient management of the organ itself. As of today, and I checked this morning, there are 113,158 people waiting on the national transplant list, which essentially means that there are 113,000 something hopeful patients who are waiting for a transplant organ to come along. The bulk of our need at this point within the U.S. is kidney transplant, so roughly 95,000 of the 113 or so that I mentioned need a kidney. Roughly 13,000 in addition to those individuals are waitlisted for a liver alone. About 4,000 individuals need a heart, and 1,500 or so need a lung transplant. The remainder of the list comprises of people who need dual organs to survive, which means that they are compromised in the sense that two of their organ systems are failing. So they might need a pancreas, they might need an intestine, they might need a pancreas and a kidney, they might need a heart and a lung. And so these are the people who are waiting for an organ today. As I said, the bulk of this is a kidney need. average wait time is dictated by a lot of clinical factors. Prime among those is the blood group type that individual has, because blood group and immunologic matching has a huge role in kidney functioning. And so because it excrete toxins and regulates a lot of our immune system and helps with that aspect, so you need to have a close blood group matching to donate an organ to another individual. Severity of medical need is also a prime factor in terms of how worse off are you in terms of ethics speak, but also from the medical need aspect of how crucially you need an organ right away in order to sustain your life. Age also has a role, not because we want to be disparate in the access that we provide, but because if you're 2-month-old and you need a heart, your lung cavity or your chest cavity can only take maybe a child's heart. Certainly an adult donor will not be able to help you. So there are those logistic kind of physical aspects that come into it. So age is another contributor. Ethnicity can sometimes play a role in kidney disease or liver disease, and so that is also factored in. And then last of all is the region of the country that they reside in. So as we see our geography being disparate in terms of access to healthcare, certainly that is echoed in access to transplant care as well, because transplant centers tend to be larger, sometimes or mostly academic medical centers, which can kind of have the volume that it requires in order to have enough referrals to run a transplant program. And so those are kind of all of the factors that can factor into how long a patient is waiting for a specific organ. The average wait time, for example, for a kidney kind of nationally can be anywhere from 1 to 6 years. Roughly in Ohio, the median time is anywhere from 3 years to 5 years for a person to get a kidney transplant. And that all depends, again, as I said, on the factors that I just mentioned. This is all a pathway for deceased donation. And so deceased donation means that if someone were to pass away, sadly, because of a horrible traffic accident, and they had registered to be an organ donor beforehand, and their mode of death was made them eligible in order for their organs to be expeditiously procured, then they would be eligible to, and of course their family agreed and were on the same page in terms of their value set that they wanted to help someone out and they wanted to donate. We would go ahead and after their death wait a suitable amount of time and then procure their organs. So this is deceased donation. The other pathway for receiving an organ and a parallel pathway can be living donation. So living donation is where people in need for transplant reach out to their community, to their family members, to their friends and their acquaintances regarding their acute need for an organ. And then the transplant center receives call from these interested individuals who call in and say, I'm not sure what my blood group is, but I might be interested in donating. I'm not sure what the process would be like. Can you educate me, and can I come in for a official evaluation, if you will? So the transplant center can evaluate multiple people in order to help one recipient out, trying to kind of ease the process on our end of things to make sure that multiple people understand that this is something that we can do for them. And this is one pathway where by donating a kidney or a liver lobe, you can help someone during your lifetime and not have to wait for deceased donation. Living donation can only be done for kidneys because we have dual organs, and so you can give one away and safely live with one. And the liver has a unique ability to regenerate itself, and so it can kind of grow back, perhaps not to its maximal potential, but still enough to sustain your life for the rest of your life. So these two organs are unique in the sense that they have the privilege of having living donation as a pathway for people to benefit.
So UNOS then would organize and monitor cadaveric and living donors. Correct. If they're anonymous. Correct. I take it?
Right. So you can have two kinds of living donors. For example, if I was in need of a kidney or a liver, my mother, my siblings, my husband, my children, any of them could do directed donation, is what we call it, where they know whom they're donating to and they have a specific person in mind. And then living donation can also be done altruistically or in a non-directed fashion. and it can also be anonymous. So I come to a transplant center thinking, I'm in the prime of life, I would like to donate a kidney, I'm also a registered donor, even though I don't have to be for a living donation. It's basically depends on the motivation of the individual, and I come in and say, I don't have anyone particular in mind, I don't have anyone in my family who is experiencing dialysis and is undergoing, or suffering from end-stage kidney disease, but I'd like to donate a kidney nevertheless. I'm less inclined to know whom that person is, and I leave it to your discretion in terms of finding for me the best possible match for my organ. And so living donation can be directed or it can be non-directed.
And then just to follow up a little bit about the regional transplant centers, so a couple questions. Can a person, so just to make sure people are aware, you can't necessarily be living in Maine, and just because you're the next on the list nationally, you get the organ if it comes up in California or something. So with the regional list, how many regional lists can you be on? And then also, how do you help people who are in a very remote area? And you were saying that could be very difficult as compared to somebody who lives around the Cleveland Clinic. We take that for granted that we're in this major area. So what are some of the issues there with the regional lists, and how do you handle those?
So OPTN or UNOS, kind of for logistic ease and for hopefully, kind of distributing equally, if you will, the access to transplantation, divides the country into 11 regions, or foci of transplantation, if you will. So in order to decentralize the process, instead of one central kind of institution in one area of the country, they decentralize the access for patients based on where they live or reside. So if a patient is ill enough to be categorized as an end organ failure patient and they are in need of an organ, then they get referred from their existing primary care physicians or their specialist for evaluation at the nearest transplant center, or the transplant center that falls within their insurance coverage. And so they would probably be moving, let's say if you lived in Maine and was a very rural setting, you would be going from your local hospital to the bigger institution, which is the nearest to you. And so you would be referred from your local folks, from your local physicians, to be specifically evaluated for whether you are eligible to get a kidney, if that's what they think that you need evaluation for. And then the transplant center will proceed with evaluation in terms of medically, surgically, psychosocially, financially, insurance-wise, dental, heart checkups. Nothing is beyond the realm of a transplant evaluation. Most patients who have one end organ failure tend to have not complementary, but deleterious effects in terms of other organ systems or the way the rest of their body is functioning. So it's a pretty thorough workup, which can last sometimes weeks, sometimes months, in terms of evaluating concretely whether they are truly in need and how acute their need is right now. So the transplant centers then kind of work as the hands and arms of UNOS, because UNOS in itself cannot, as a discrete entity, provide transplant access, because it needs the partnership with multiple transplant centers in order to make this happen for multiple folks who live around the country. A transplant center, upon thorough medical, surgical, and psychosocial workup, will either add that patient if they understand that this is someone who desperately needs a kidney, for example. They will put the patient on the wait list and register them with the UNOS, saying, this is an official patient, we are adding them to our regional list. And the way our list is run, the next time someone comes up who is a deceased donor, and the blood group and all the other particulars immunologically tend to match, this is the status of this particular patient listed at our center and how acute their need is. And so there's a grading scale in terms of how acute your need is. For most organ systems, if you are in group 1, which means you desperately need one, you're probably in the ICU and are very, very sick and are kind of hopping back and forth between community, going home and then coming back into the ICUs, and have substantial effects from your kidney or liver or any other end organ disease, then you are prioritized to be at the top of the list, if you will. And then subsequently, based on your medical need or the way that the organ allocation systems have been set up through policy by UNOS, you'd be categorized in a specific category, and then you'd wait there in terms of finding a possible match. After the registration, you are kind of under the official oversight of UNOS or OPTN, if you will, in order to be considered for an official organ offer. So in order for a patient to officially receive organ offers, let's say someone were to pass away and they happen to pass away at a sister hospital, they wanted to donate, the organ procurement happens at that point, and before that happens, we tend to match people to what organs they are able to donate, so that there is no time lost when organs are sitting waiting on ice and we are scrambling to figure out where the people are that need to house these organs, because this is a scarce resource. It's a huge investment from someone in terms of their value set in order to go ahead and feel comfortable and feel aligned with the values that make donation a possibility. We want to honor that gift and make sure that every possible organ that we can fit with someone else finds a good home and is able to benefit a recipient on the other end, because that was the intent of the donor. If patients are perceived by transplant centers or by UNOS criteria, because UNOS kind of modulates the whole mechanism by oversight and official policy, where they kind of figure out, with the help of volunteer expertise holders from the medical and the surgical community, in terms of what translates into acute need, what translates into moderate need, and what translates into they definitely need a transplant, but perhaps not exactly in this moment in time, and they might be able to wait on, let's say, dialysis for 2 years, and we might be able to push it off to see how the kidney responds to dialysis, and then see if they acutely need an organ. So based on medical and surgical expertise, that is kind of nuanced out, just by virtue of policy that UNOS kind of dictates. But if a patient is thought to be either too well for transplant at this point, where they are just not in that danger zone that they need an organ acutely, or they are considered too sick for transplant because you feel that they might not be able to sustain physically a 6-hour, 8-hour, sometimes even 11-hour procedure in order to do a heart or a lung transplant, or they have difficult circumstances socially or psychosocially limiting their ability to benefit long-term from an organ transplant, they can be either evaluated further, and so they are kept on the kind of the patient roles of the transplant center, who kind of keeps a keen eye on them, has them come in every so often, every 3 months, maybe 6 months, maybe once every year, to kind of make sure that they touch base and see where the need has fluctuated, if it has at all, or if it has shifted to more acute need, then they are liable to put that patient on. But and then they keep the patient under observation, or if they are considered not suitable for transplant based on their unique circumstances at the moment, we kind of keep an eye on them and make sure that they receive care regardless, and the transplant center will then make appropriate recommendations to their referring physicians in order to kind of modulate what their disease process looks like, because they've had an in-depth evaluation at this point, and so both teams kind of make sure that the patient is optimized in terms, even if they are not put on the list for transplant.
I wanted to ask you, does it ever occur that a person is next on the list or closer? I'm not sure how this would occur, and you have a deceased donor, and they're even though they're within that regional system, they're too far away at that time to receive. Like, how do you make sure that a person, I'm sure they're careful about it, and then, some people might even have more money, let's say, to take up residency closer to the transplant center, so that might become an access issue. How does that get?
So based on the fact that we have so many people waiting nationally for an organ, at this point the system has not decided that it would be unethical or stilted for people to multi-list. So let's say I owned a jet, and I could come from Maine to Cleveland in the blink of an eye or in the space of a few hours, and I have the financial wherewithal to multi-list at multiple centers. So some people do that. They will list at their own hospital or their own primary transplant centers where they live within driving distance, for example. Or after waiting on the list for a couple of years, they understand that the list might be fairly long and their number or their chance to have a transplant is not coming up. And they might go to another state and see which transplant center they want to seek out and multi-list. Generally speaking, 1 or 2 is usually the max that people can list at. We do sometimes see patients who are incredibly fortunate to be able to list at maybe 3 centers, but I think that's where we unofficially kind of cap it, because you'd have to be very centrally located in the country to be able to fly to 3 disparate areas geographically and be able to make yourself available for that offer to kind of, take fruit. Organ offers usually happen within a few hours frame time. So we educate all the people extensively, kind of ad nauseum, that they need to be aware of when the phone rings. They're given classes after their evaluation if they're put on the wait list, before the wait list, upon waitlisting, and after waitlisting, and upon each successive evaluation that they come in for or checkup with their transplant team. They are re-educated again and again on the importance of making themselves available, keeping their voice message boxes free, and being able to have a mechanism within the night of responding, which means for some folks that they need to have transport at the ready. And as they kind of grow towards priority in the list, they get more and more frequent re-education in terms of that okay, chances are high that you're on the top of our regional list in this blood group, for example. Chances are the next time we have a donor that happens to have your blood group, you might get called, and so you might get a heads up. Ideally, if that heads up is not able to be made in time because we didn't know what the next donor's blood group might end up being, then they are called within the night, and essentially they have a few hours to make themselves available and kind of drive up or fly up or whatever they can manage in order to get the organ. Because upon death, there's only a discrete amount of time that you can or must wait after the organs must be procured. Once they're procured, they're kind of put on ice, and there's a limited viability time where the organs can optimally function in a recipient, with lack of blood flow at this point, right? So they are kind of taken out, and we are then in a time crunch, and we need to have that person come up. The way organ offers are offered is that they will call you and say, this is the point we've been educating you for. We have an organ available for you. What is your answers? And at that point, they give you an additional kind of informed consent opportunity to kind of replicate the process that they've already done probably a couple of times before with the transplant center, and give you a last-ditch kind of chance to say yes or no to transplantation. Very rare that people say no, but they have the flexibility to do that because multiple years might have passed since the initial education. They might feel, for example, for kidney transplants, they have more comfort with dialysis. Things might have shifted in their social circumstances, their age might have increased, whatever the circumstances might be. We at the transplant centers tend to not hold patients accountable for signed forms when they said, okay, I'm put on the wait list, I give consent for transplant surgery. We kind of re-ask them in the moment to make sure that they're okay with that. So that kind of dual touch consent system is kind of integrated so that patients can say no. Generally speaking, these are really sick patients and they're really anxious to get an organ, and so most of the times the answer is yes, and they have made reservations, they have made preparations to get themselves to the transplant center post-haste so they can, in order to be transplanted within the night if that's the case.
Right, so you have a very motivated group, generally speaking, but of course there's always exceptions.
Yes. Mm-hmm.
So let's shift a little bit and talk about your role on the transplant team at the Cleveland Clinic. Can you explain kind of the structure of the team, what kind of, who's on that team, and what your personal role is on it?
Sure. So I represent transplant ethics on the transplant team that I serve on. I serve on multiple transplant teams. For kidney and living liver donors, both the living donation possibilities, I act as a consent monitor and meet with them all one-on-one in most circumstances in order to kind of flesh out their value set, to kind of nuance for them whether that value set lends itself to living donation. I inquire about their motivation to donate. I assure our team that the candidates are not feeling pressured or coerced or even subtly influenced by any other external means to donate against their better judgment. That's something that we want to make absolutely certain, especially so for anonymous or non-directed donors. We want to make sure that they are under no pressure to donate, and that stands true for directed donation too, because most people are donating towards their loved ones. We want to make sure that their anxiety in order to help or save their loved one is not pushing them towards donation against their better judgment and they feel fearful about it. So we talk about that aspect. For transplant recipient candidates that I meet with, people who are undergoing the initial evaluation before they're waitlisted, or people who've been waitlisted and there's been a long time they've been waiting and we feel that they could do with some re-education. I see kind of both those sets of people. I meet with a few who are psychosocially more complex. They might need more coordination of care than usual. They might suffer from intellectual or other disabilities, physical limitations at this point because of increasing age and their end organ damage, or might need special accommodations. And I also meet with them and see if they're truly moving forward with transplantation with kind of clear, aligned goals in mind in terms of the fact that transplantation and the surgery and the post-op care, which includes long-term graft rejection, immunosuppression medication, can be a long path for them to kind of follow and wrap their heads around. And so we want to make sure that they do understand the philosophy behind transplant. They understand that they will be convalescing in an ICU. If they have complications, maybe for an extended period of time, they will need to go rehab. They will need family support to support them. They will need to take medications religiously for perhaps the next 5, 10, 20, sometimes their whole lifetimes in order to make this a success. So we want to make sure that they are optimally supported from the get-go rather than catching, incidents on the back end. So we meet with all of those people, and the idea again is to kind of inform their consent process to make sure that they fully, truly do understand in kind of layman terms rather than physician speak. And I have the luxury of meeting with them one-on-one for more time than the physicians might have, and to kind of build a rapport with them and to make sure that they are connected within their families. Sometimes as people age, they hang on to their independence and have kind of mental blocks around asking for help from other people, and our job is to kind of tell them this is the moment that you need to be connected in order to kind of optimize the benefit that you might have from something that someone had to die to give up.
Sure.
In most circumstances. Because kidney end organ failure and liver end organ failure, and because of the acute needs for people who need lungs or heart, their health is deteriorating at that point. They might not be at the moment of, optimal faculties in terms of understanding. So liver failure, acute kidney failure can have signs of uremia or what we call encephalopathy in terms of liver failure. They might not be in the best moment of time to recall what was told to them 6 months earlier in a rapid fire 10-day exhaustive evaluation where they met person after person in the hospital, telling them about a different aspect of transplantation. And so, as I said before, the recipients, upon waitlisting and afterwards, kind of get education classes with nurses, social workers within the hospital to kind of keep up to date, make sure that their questions are answered, to make sure that they're engaging and are coming to learn again and again, to make sure that the information that they received in the beginning is kind of fresh in their minds. We also encourage them to bring their caregivers, their wives, their spouses, their children, or whoever is going to be their kind of social support network in the post-surgical phase of their transplant, in order to make sure that multiple people around them are well prepared to catch whatever it is that's going to happen post-transplant. And then also to kind of see where they fall in terms of being able to align themselves with the reality that they might be shifting from an acute disease process to a chronically managed condition, right? So transplantation, diseased or living, does not offer a cure for all things that ail you. It is a shift to a chronically managed condition in the sense that you're on multiple medications, sometimes 30 to 40 pills a day. And so that number in itself, and the fact that you have to take them at certain amounts at certain times in the day and religiously day after day after day for years until your physicians feel that the organ has adjusted to being in a foreign environment within the recipient's body, they need to kind of come to consensus and come to the realization that there will be a lifestyle shift in terms of what their disease is now going to look like. So I tend to align it to how you would manage diabetes, in that you can be diagnosed with diabetes, but then enter a phase where you need to align yourself with, I have this issue going on with my body, and these drugs, this insulin, this medication is kind of keeping me at the optimal that I can be in the long run so that I can outlive my disease process rather than suffering acutely. And so once you transplant a foreign body into, and by foreign body I mean the transplanted organ, into a recipient's body, the body tends to mount an immune response. And these medications that I mentioned before are keeping that process at bay. For whatever reasons, medical community has not come to consensus why that might occur, but sometimes it happens regardless of all the care that we're providing and all the time and effort that the patient is putting into taking many of these drugs, that process takes off anyway. And when that happens, you have what we call graft rejection, or the loss of the organ. And so if that should occur, we tweak the medications in order to optimize the state where they are. For kidneys, they might be put on dialysis. For liver, they might be put on higher doses of the medications they were on, and then slowly they shift towards moving back to the transplant list that they were once on in order to be now in the running for a second organ. So retransplantation is becoming more common globally, simply because as we age and as we do more transplantation and organs last only for so long, you see more and more people gravitating towards that because transplantation is becoming more mainstream than it once was.
So medically, a person could do, because we can monitor them and help them so well, they could actually live much longer than they did at another time. And then it just becomes, you're going to have another transplant.
Exactly. So for example, for pediatric transplantation, if you're transplanting someone at the age of 2 months or at 2 years, inevitably you will reach a point where the organs will not be able to sustain optimal functions as their body grows. The organs tend to grow with them, so this is something unique to transplantation, that with peds cases, for children, the organ tends to grow with them, and it's miraculous but our bodies are able to maneuver around that. But unfortunately, all transplanted organs kind of have bracketed advantages, the way I tend to think about it. You can optimally live with perhaps a decade, 2, maybe even 3 if you're in excellent health and your organ gels well with your body. But there will come a time, I'm sure, that for pediatric recipients that they'll need a retransplant.
You had mentioned in conversation that the Cleveland Clinic for Living Donation has a wider age range than many other. Can you just mention what that is?
So the Cleveland Clinic, being a large hospital system and a well-respected academic institution, has a large volume transplant center. So just for example, we just looked at our numbers for last year for the amount of transplants that we did. 130 kidney transplants were conducted, and 51 transplants were from living donors just in the past 1 year, for example. So we tend to have an open philosophy when it comes to donation, and we tend to see this as a service that we provide to people who are in need. And so we tend to be I don't want to say liberal, because we are really deliberate about the people that donate with us, because we want to make sure that, especially living donors, because they are doing this primarily as an elective procedure based on their motivation and their value set. We don't want to add them to a patient list. We want to detract from those suffering from organ failure. So we want to assure ourselves that we're not putting a living donor who is in optimal health and who would otherwise might not suffer from any disease long term, are not putting themselves under undue stress in order to donate just for the sake of someone. We do consider donors from 20 to 55 to sometimes even very well-functioning, really healthy 60 years old for kidney donation. And for liver donation, we evaluate candidates from 20 to 61 years of age. The 61 years of age is a recent move based on our increased understanding of how living donation happens and how well these people are faring overall. So deceased donation is kind of the older counterpart of living donation. Living donation is a more recent change. In the last 10-15 years, it's taken on force, and more people tend to be educated about it and want to come ahead and donate. And so we have a a smaller amount of data in terms of how longitudinally that they are doing. So UNO's policy dictates that we follow everyone that donates at the transplant center for at least 2 years, even though most of these people, based on their health and good recovery and lack of complications, are able to get back to their jobs and are able to feel optimally healthy around 3, sometimes 6 months. Sometimes it takes up to a year based on your body physiology and how big a toll the surgery took on you. But in most cases, these people are doing well and are on their feet and are going back to work, to jobs, to their lives, to the kids fairly soon. But we do tend to follow them for 2 years, just wanting to make sure that they're doing optimally in the life after donation and that we have not disadvantaged them at that point.
You said you'd raised the age to 61 recently from 60 or something, or just based on statistics?
Just based on statistics and looking at how well the living donors were doing, and as each transplant center gains more momentum, but also gains more experience with kind of donating 55, 56, 57-year-olds, tend to understand that if well picked and if you're picking people who are in the prime of their lives and they take good care of themselves and we take much pains to make sure that they are on the optimal path to recovery, that there's no reason to stop at a specific age such as 55. Certainly we probably are in the extreme because we have and feel an obligation towards recipients who are waiting a long time for liver or kidney donations, but there are transplant centers within the US who are more conservative, tend to only evaluate people who are 25 to 55. Some transplant centers evaluate people from 20 to 50. So it's based on your hospital systems and your transplant center's philosophy in terms of how well you feel equipped to take on the risk or the responsibility, if you will, for a patient who might suffer consequences. But we have a very thorough evaluation phase regardless of how healthy you might seem on the surface. And so we do CT scans, MRIs, sometimes even biopsies of the liver in order to make sure that you truly are healthy and we are not disadvantaging you in favor of the recipient.
Sure. And I could actually imagine that having, as long as they're in optimal health, someone who's somewhat older, they may actually have more time or could be retired already and that could make them actually a good candidate because they're going to use their downtime. They're not going to push themselves maybe.
Certainly. So at different times of our lives, some people actually come to us and say, we read about your policy of, I'm 59, I'm turning 60. Most places I called said, no, we don't really evaluate people around your age frame, but I want to explore this and see if this is a viable opportunity for me. And since you are generous enough to give me an opportunity to kind of flesh this out and see if I might be eligible, I want to come in and do that. I'm retired or I own my own business, my kids are grown up, I have more leisure time, and it's been growing on me, this responsibility or this feeling of motivation that I want to contribute, and this is the way I want to do that. And so we have people at all spectrums of ages that come in and have different motivations. Certainly if you are financially well cushioned, have the ability to be senior in your work and have the flexibility for extended time off, those things can certainly play a role in order to make it easier for you and your spouse and your kids to kind of bear the 2 or 3 months that you might be down after donation surgery.
Thank you for listening to Conversations in Bioethics, a podcast brought to you by the Cleveland State Department of Philosophy and Comparative Religion. Produced by faculty member Tony Nicoletti in conjunction with the Center for Instructional Technology and Distance Learning. For more information about the Department of Philosophy and Comparative Religion course offerings, please visit our website at csuohio.edu or call 216-687-3900.